I work as a gastroenterologist increasingly and less so in general medicine, but doing endoscopy, which is where I was this morning. And initially, as we heard, involved with hepatitis C treatment, all the way back to attending St Vincent's outpatients where Red Cross would send the patients that they'd identified with hepatitis C back in the days of interferon. And then obviously now we've got much better treatments for hepatitis C, and sort of patients who would tend to come to hospital and come to outpatients with hepatitis C, they've been cured. And what we've really struggled with Hep C is getting access to patients. Perhaps, continuing to drug inject, really needing to get into those areas. And they're not going to come to outpatients with all their mates injecting. So it's a difficult area, and the sort of hierarchy in a hospital, etc., doesn't suit well for that. So for a long time we've had GPs send us geezer forms that we fill out and agree to. They do the treatment in the community. There's varying degrees of interest in both GPs and in the past gastroenterologists in terms of treating hepatitis C. So it's not everybody sees it as something that they want to be involved with, put it that way. And then obviously in the more latter years it's now hepatitis B, and particularly in Bendigo we have a largish Karen population from Burma out to Thailand and then moving to Australia, and then Bendigo's become quite an area for them, and that's been attracting more Karen people and more families to come to Bendigo. And so it's identifying hepatitis B in those groups. They've generally had the blood test done, etc. But there's still large communities within, well, we'll just say Victoria, who've come from countries where there's a high rate of vertical spread of hepatitis B from mum to child, where the person's quite well, and unless you actually go doing tests for hepatitis B, you won't recognise it. They won't necessarily have abnormal liver tests. And so it's important to identify those people, because they can go 30, 40 years with nothing happening, but develop a liver cancer. Liver cancers grow very quickly. So if you're not doing regular testing over certain ages with ultrasound, etc., you'll miss the opportunity. There's a little opportunity there where the tumour's at a size that you can, going up through the groin, and as I try and explain to people, so if you have a grapefruit and a lemon, and the lemon's the cancer and the grapefruit's the area that you can knock off, so up to a certain size you can do that, and the rest of the liver remains healthy. And so there's a number of patients we've seen with hepatomas who've been treated in that way. A few of them have had surgery, but most of them, the problem is when it gets too big, then there's really not a lot that you can do after that. There's various chemotherapies and there's some new immunotherapies that are out and about, but it's still a pretty dismal prognosis for people with liver cancer. So there's this, and unfortunately a lot of the patients get a bit they're having ultrasounds every 6 months, which are normal, and we keep explaining to them that it's very important, that ultrasound though, because you'll have no symptoms. When we've spoken to large groups of Karen people here in Bendigo down at the RMIT, the question that I keep getting asked is, but what will the symptoms be for this little cancer? And the problem is that there aren't any symptoms. You either find it through doing these regular ultrasounds. If you've got symptoms and pain, then it's clearly not going to be a 15mm lesion. So I was actually happy to take questions about hepatitis, whatever you wanted. Sure.
Is best practice every 6 months for an MRI?
Not MRI, we'd use ultrasound. Okay. So it depends. There's various guidelines around the world. With African people, it's probably a decade earlier because they get their cirrhosis. The Hep B may even be different, like genotypes. So it seems to be a more aggressive disease, and therefore they've got their cirrhosis, liver cancers more in their late 30s, 40s. So we would start screening earlier in them. Generally for males over 40 and females over 50 in the Asian group that we're looking after. But that's assuming they don't have a family history of liver cancer. So I think there's a sort of target of around 2 per 100 per year, where there's a certain mathematical target where it becomes appropriate and useful to do the screening. And so it really depends what the background risk is. But the 6-monthly ultrasounds, as we know here, that overloads we can't book an ultrasound for 6, 7, 8 weeks. So it becomes a practical problem, like you're seeing them. The safest way is to see them, and they've got their blood tests and their ultrasound when you see them. That's all a little package, and then off they go. Our problem has been, if you've got such a long wait for ultrasounds, they've often not had their ultrasound when they have that 6-monthly appointment. And we learned from the oncologists, one who'd worked in Canada, where they have a paper round. So when they have an outpatient clinic, they have an outpatient clinic with all the UR numbers for the patients who are going to attend, and then they have a paper clinic. So that might be half a dozen people, they haven't had their scan done by that appointment just recently. I don't really need to see them for 6 months. But in a month, I'm going to pull up their paperwork and make sure they've had their scan, and more particularly that it's okay. I saw a patient the other day who had an ultrasound in October last year, and she's on entecavir for Hep B. She'd be late 40s, and she knows about the risk of liver cancer. So when I saw her, I said, "Did you ring me about this ultrasound?" "No, I didn't. I just assumed you'd ring me if there was a problem." And there was an abnormality on that scan. So you try to make people responsive. Yes, there's a couple of problems with that. One is the scan may not have arrived, may never have seen it. And two, actually, I don't get the liver cancer, you do. So you really, if you're having a scan done to find the cancer and find it early enough to have some appropriate intervention, you really need to know that that scan's okay. And to leave it in the lap of the gods doesn't really work. Correct. Whereas others harass us quite a lot about wanting the test results, which is good. Yeah.
It sounds like there's some significant barriers for people to take ownership and accountability of their liver health and liver disease. As healthcare workers and as healthcare professionals, what can we do to help overcome getting people to see you and be proactive about their health?
Well, I suppose there's two things I'm interested in getting involved. So here we have outpatients and we have our rooms. So I find in the rooms it works very smoothly. And the other thing about my rooms is all the results as they come through our office all sit in a box, which I see before they go into any scanning or filed, etc. And sort of in outpatients, there's a lot of patients, a lot of different people, so it can be difficult from that point of view. I guess for a whole range of reasons, people either don't want to be told what the doctor's going to tell them, I guess, which is fair enough. It's a bit of a pain coming to the hospital. They don't think anything's going to happen. I should be okay. And to some extent, we're under such pressure that I'm not. There's a certain amount you can do. I think the paper clinic bit is something that we've devised so that we at least, hopefully, it won't completely eradicate it, but narrow the risk of having a test which wasn't followed up on. Yep. And with liver cancer it's much faster than bowel cancer. So if you look at bowel screening, it's over some years. You look at cervical screening, it's all been stretched out for more years, whereas liver cancer has not. And that's because liver cancer is very aggressive and they grow very fast. So it is a small opportunity you get, and I guess we try and encourage patients to know more about it and to be involved, but sometimes that's difficult.
Thank you.
Yeah.
Dr. Fisher, what are the kind of more routine blood tests that GPs would do that would indicate that they may need to look for, liver disease? What do they mean? So what are the...
Well, in terms of hepatitis B, I think one thing is where are those people from? Where have their parents were from Vietnam? So have they ever had hepatitis B testing? Has anyone ever done that? Because their FBE, their liver tests, their haemoglobin, all those things are going to be normal. So one thing to have in mind is there a background risk for this person to have hepatitis? I suppose, a similar way to hepatitis C, that, have you ever used drugs, done any tattoos, etc., etc. But that vertical spread of hepatitis, many of these people who've come from, there's none of this testing done on the Karen people when they're in the Thai camps. So there'll be no background to this. However, when you talk about liver cancer, they will have knowledge of people who in their 40s have died. There was something wrong with their liver, we're not sure. But they won't have it defined that it was hepatitis B and it was a hepatoma, etc., etc. So I guess that'd be one thing. Are there clues there? I guess clues in terms of lifestyle, and would they, regular liver tests. A lot of boys don't go to doctors at all, so I guess it's a matter of when they do, you collar them and try and do those things. And we know from the young Karen men in our clinic, it's a huge thing for them to take a tablet every day. So even when we have identified that they've got hepatitis B, even when we're identifying that they've got abnormal liver tests and therefore are at risk of getting cirrhosis, and indeed you can get liver cancer with hepatitis B without cirrhosis, there's still really, it's still very difficult for them to take a tablet every day. And we're often pinning them down saying, well, how did the 6-month script? I know from the blood tests, because I'll do the blood tests, but I know the blood tests are abnormal and that should not be the case if they're on treatment. So then I go back and I talk to them about the script. How did a 6-month script get you all the way through when you've only got 2 months of it? How did you get that 2 months to stretch to 6 months? And so occasionally we even go back and we give them just a month's worth of entecavir, or 2 months, and keep talking to them, keep having a conversation with the interpreters, keep getting across to them the importance for them. Yes, I know your mates are not on these tablets. I know there's hepatitis B, but this is for you. You're going to have a family down the track. You're going to be 40 and you've got a liver cancer, which may or may not be curable. And then you're going to be thinking, well, what about if I'd done something earlier? So it's a matter, and sometimes it just takes time for them to gain the trust that what you're talking about is real, and showing them the numbers. I find the numbers very helpful. Hepatitis B was suppressed, it was good numbers, liver tests were normalised. Now it's back to 6 million and your ALT is 140. There's no mystery.
The interpretation of the hepatitis B viral load. So how often do you do that?
Well, I guess if someone's got abnormal liver tests and hepatitis B, then I think a lot of GPs would feel uncomfortable about managing that. And they would probably need some direction from hepatology people. And I think, it's just, as you know, the interpretation of hepatitis serology sounds very simple when we see it all the time, but it ain't simple. And, there's a lass I will look after who was vaccinated 4 times in Tasmania. They could just never get her surface antibody positive. That's mainly because her surface antigen was positive. She had hepatitis B and she had it from mum, because I look after the mum. So, so she's on entecavir rather than getting vaccinated. So I think it's difficult for GPs to be. I think if the liver tests are normal, I suppose even a GP, because as you know, Medicare, you get 1 hepatitis B DNA a year if you're not on treatment, and 4 if you are. So you very quickly get into trouble if you're doing Hep B DNAs and you're not really understanding what you're doing.
Because then people get bills, don't they?
They do. And we've got a few, every now and again, some of our young women who are pregnant require treatment for their hepatitis B leading up to delivery, because they've got such high viral loads. They're not unwell themselves. Their liver tests are normal, but they've got such a viral load that from the baby's point of view, there's a risk of transmission even if the baby has vaccination and immunoglobulin at birth, which is what all the Hep B babies are going to have if mum's got Hep B. But there is this group who've got extremely high hepatitis B levels, so we put them on treatment. But then you find someone's already done it, you're following them, but they've had 2 hepatitis B DNAs, one by the obstetricians, one by someone else. And once again, I think it's $100. I don't know, how much is a Hep B DNA test? What's the bill that they get? Do you know how much it is? So then the clinic picks up the cost of that. So I think for most GPs it would be, I think it's thinking about it, and if the liver tests are abnormal, sure you could do a hepatitis B DNA, but I think generally people would want someone else to have a look at that. Katina.
Thank you. Liz, I'm interested with the precipice that we're on right now in health, being community health traditionally, and acute health. We now have opportunity with local public health units to influence population health on a greater level than we have had in past times. From your perspective, what would be, do you think, one or two of the most important messages that we from the public health unit can focus on to improve the health of people's liver through the region? And I mean through the viral hepatitis, fatty liver disease, non-alcoholic, etc. Aside from those messages that we are used to hearing being exercise, eat well, don't drink. Are there any other wise?
Well, we all follow those, of course.
Well, yes, of course we do. Yes, I do, of course.
So you mean through general practice, or do you mean non-medical?
No, I mean from population health through, so with the Loddon Valley Public Health Unit, which the three of us are from,
yes.
I'm just interested in how the bridge between community health and acute health can impact, what impact we can have, because there is some discussion that obviously public health units will be taking on some more work of what Central has been doing, and one of those pieces of work will no doubt be other communicable diseases, including viral hepatitis, I would presume. So I'm interested in liver health and what we can do. Where do you think there's a bridge that can be created to support people doing proper testing, GPs understanding, community health engaging with stakeholders?
We have been involved with the GP. There's a central database for GPs to go to for looking up about hepatitis B, or looking up Hep C or hemochromatosis, fatty liver disease, a whole range of them. And there's a sort of a basic template, and then through one of the local GPs, Jay Banerjee, and then he sends the gastro ones on to me, and we have a look at them, and we look at the language, and that's what and there's, in fact, there's various levels of there. Sometimes I've thought there's far too much, but they're drop-down boxes, so the GP can either look at it and see, yes, okay, and if I'm going to send them to the hospital to see a gastroenterologist, hepatologist, these are the things they're going to be interested in doing. And so there's some simple tests there to at least have done before. So that's on the pathways, yes. Sorry. So that would be a way of and simplifying it, and so that GPs can get something they can drop down in. The idea is that they use it at the surgery, see a patient, drop down. They either might want more information, so if they were studying for something, or if at least enough to deal with that patient. As you say, they've got Hep B, I don't know much about Hep B, go to the Hep B page, and it's not like opening Harrison's and reading about Hep B, which sort of blows their mind, and they can't do that in the time. So it's quite, so that would be, and they're being expanded all the time. They've got them rolled out across the state and in various places. And then there's sometimes some nuance around what the Austin might be able to do for somebody, needing a gastroscopy or having Hep B might be different to what we can offer here. So there might be some things that we can put in place and highlight the things that we would want to see in the ID clinic. Whereas, the Austin might have, they've got 30 gastros, so it's less of a, here we've got 1.5, so it's sort of a bit difficult.
So here's some educational components for health workers about access.
Well, about where that access is, I guess. It's simple.
I'm also hearing that we need greater engagement with the community, understanding the illness. Is that?
Yes, but I don't know how. I guess we're stuck in that acute, and I think even the acute health. I think if you went to Bendigo Acute Health and said you're monitoring someone for liver cancer because they've got Hep B, would almost sit outside their ambit. It's not something. It's not what they see as their role. It's a role of seeing patients, treating them, and then off they go, but not this callback, not this sort of bring them back. We've got enough problem with the people needing to come, not bringing people back to be seen every 6 months, overwhelm our ultrasound service. And so the pressure would really be that should be done in the community, but how do you get it done in the community? Where's the expertise in the community? How are you going to track those patients? How are you going to... We were just talking about follow-up of... we know about hepatoma, we know about ultrasounds, we know the importance of that and finding early cancers, but it's actually... when you come to actually do that, it's not easy.
I'm just thinking of the overrepresented populations that are in the Loddon Valley region with hepatitis B and hepatitis C.
Well, we've cured the hep Cs.
Yeah, nearly.
Mm.
Well done. Yeah. Okay, thank you.
Can I ask, so if I was to go back and inform our HMOs and medical officers, would we direct, say we got the test back from their bloods and check out
The doctors.
Look up Murray Mental Health, Primary Health Network, go on to Pathway, and then what? Type in hepatic or liver?
Not hepatitis B, probably.
It's very disease-based.
So, but you're talking about the doctor having hep B, or you're talking...
Yes,
because that raises some other issues.
Sorry, within our service, so they don't really look at general health, we're on mental health, they tend to be very heavily mental health. But the general health, they do oversee a bit of it, so then in that household, hopefully to the GP, which look up that if we have more information so that the HMO, medical officer or the GP,
Has
had info up
yes. Yes, absolutely. And if it's just point form, what you need to do is some liver tests, an FBE. If liver tests abnormal, reasonable to do a hepatitis B DNA. I guess, and then it's interpreting, the surface antigen versus the core antibody versus the core IgM. Well, even then you've lost them. And so when you ask for hepatitis serology from pathology labs, you get various things back. So they'll do a core IgM because they're looking for acute hep B. So IgM stays there for any viral infection. So IgM goes up for about 12 weeks. So if someone gets glandular fever, they'll have EB virus IgM for about 3 months. And then in that time, their EBV IgG comes up and then stays forever. So there's 3 sets of results just there. You can have, you think it's glandular fever, or a whole Ross River fever, or hepatitis B, a whole range of things. So you can have IgM and IgG negative, which means they've never had it. You can have IgG positive and IgM negative, which means they've had it at some point, probably beyond 4 months ago, but they're 56 and they might have got their glandular fever at 14. Their IgG, it's actually part of the immune. That's what gives you the immunity to that disease. That's why you tend not to get it again. So the body's got that, so you can track all these IgGs. And then the IgM, if you happen to get the IgM positive, then you know this is an acute infection. So what the labs are thinking about is you're wanting to know if this person's got... So someone sends off the hepatitis serology because they've got abnormal liver tests or they're jaundiced, and the hep B core will come back, but it will be the IgM, not the IgG. Whereas we're interested in the IgG because we see people who've been vaccinated. Partner's got hep B. They've gone to the doctor said, you need to be vaccinated. They've vaccinated them. And then you find, yes, they've got surface antibody, therefore the vaccine's worked. But we go and look at the core and they've got core IgG, meaning, no, you've already actually had hep B. But as an adult, when you get hep B, you tend to clear it. So it's got nothing to do with the vaccine. But you happen to be, you've got hep B as an adult, 95% of those adults will clear the hep B. It's still in their system in minute portions, but they haven't got surface antigen and they're not going to give hep B to anyone. When babies get hepatitis B, 95% of them keep hep B. They remain churning out hepatitis B virus from their liver.
They remain immune to it?
Who? Which ones?
The adult remains.
Yes. Yeah, they're immune.
The baby doesn't.
Well, the baby, well, they're still actually actively got. That's this vertical transfer that we see in, the 20-year-old who's got hepatitis B. So if we see acute Hep B, which occasionally we see, and we go out 6 months, almost invariably as an adult, they've cleared it.
So once it's cleared, does that mean they stay in clear?
Correct. The only time that things, as always, you can never say always, never always in medicine, but the only time it becomes relevant is later in life they've got lymphoma and someone's going to give them rituximab or some other potent immunosuppressive therapy or very targeted therapy. And in those situations you have got hepatitis B still in your liver. So hepatitis B is a DNA virus, hepatitis C is an RNA virus. So when you clear the RNA virus, it's gone, it's nowhere around. When the DNA from Hep B gets integrated into the nucleus of your liver cell. So it's always just a little bundle there. But it's suppressed and everything's fine, but you give them rituximab and the risk is they'll reactivate the hepatitis B, and there's been deaths from reactivating hepatitis B. Yeah, well, that's what the oncologist will go at that point when they're going to use one of those drugs. They will do a core antibody. And if the core antibody is positive, they'll ring you. And then we'll work out, we're going to start and take, what are the chances? Often the liver tests are normal. They've got a core antibody. They're going to start them on something. And they might do it's oncology, so they might follow their liver test monthly. If they see any flick, which of course flicks in liver tests can be for all sorts of reasons, they'll do a hepatitis B DNA and just see whether there's a rise in that.
So would you need, if your Hep B, so if your Hep B was cleared as an adult, would there be a reason to go back and see a GP and have another test?
Not usually, no.
Yeah.
And to the extent that if they had abnormal liver tests and they've cleared Hep B, I would not be chasing Hep B in the absence of immunosuppressive drugs. I'd be looking for fatty liver or alcohol or medications or some other cause for their liver.
So Dr. Fisher, if you come infected with hepatitis C and hepatitis B and you treat and successfully cure hepatitis C, is there a danger then that hepatitis B would reactivate?
It's been said that can happen. But then we would generally, as you know, sometimes we will actually start their Hep B treatment, settle things down, and then go on and treat their Hep C. Depends how I guess, high that hepatitis B DNA was. But there is some suggestion, yes, so the liver's busy fighting the Hep C and not worrying about the Hep B, which is there, and then when you get rid of the Hep C, the Hep B kicks in. And then you'd expect the liver tests, like they may have been quite normal when you've cleared the Hep C and now you've got this transaminase rise. Their PCR is still negative for Hep C, so obviously Hep B may be active. And maybe, if the patient, as we've had a few patients in their 50s, we've started them on entecavir, treated their hepatitis C, their C's gone and they remain on. The only issue there is they're on entecavir for life.
And we talked today about treatment and the difficulties with adherence to treatment, like daily tablets for the rest of your life. So what is actually the risk of stopping treatment and starting treatment and things that we know happen when people don't? Well,
there's a risk that you'll flare, and you'll often see a flare. So those pregnant women we've treated for 6 months post having the baby, getting over breastfeeding and all those risks for hepatitis, you'll often see a flare. In some of the oncology patients, there's been deaths. So people have gone on to treatment to suppress their Hep B, they've finished their rituximab, everyone's happy, and they've stopped their immunosuppressive, and they've had a flare which has been strong enough, because it also depends on how much background liver disease you've got. So if you're a cirrhotic, and then you have a burst of Hep B, you may actually go into liver failure, because you've damaged enough liver cells, which in time may recover and you might get through it, but you may not. So yes, we are anxious about people coming on and off treatment. that's a risk to the person themselves. I guess the broader risk is if you've got people taking a viral suppressive drug, because we don't treat many viruses. So viruses are not something we generally treat. And if you suppress, so you've got the hepatitis B, it's churning, like all viruses, they're constantly making changes, little, changes in their DNA, etc. And as we've seen with COVID, it comes up with one that can get around, it's more infectious, maybe less dangerous, etc., and away it goes. So if you do that with hepatitis B and they're on entecavir, off entecavir, if the entecavir is there and it's suppressed, it can't come up with these mutations. But if you've got entecavir in the bloodstream one day and not another, and the hep B is growing and coming, it's making those mutations in the presence of entecavir or lamivudine. Some of the early hepatitis B drugs were quite renowned at the end of 12 months for people to have made mutations which get them around lamivudine. Entecavir is less than 1 in 100 per year. So we know entecavir, if you take it every day, it's very potent at stopping hep B, and it's very potent at controlling mutations. So yes, then that's a risk for the community, because now you're going to have a hep B that's out there in the community and intrinsically is now immune to the treatments that you've got. So as you know, we've actually ceased a couple of people on hepatitis B treatment because they just, for various reasons, despite lots of discussions and lots of talk, they just can't do it.
So that means so that you kind of doing something, if you took it one day and it's 4 days, and one day it really actually happens.
Well, I suppose there's two injustices. One is that's not going to help you, and number two, you could create a version of the hep B that's now able to get around, just like antibiotic resistance. So there's antiviral resistance in exactly the same way. So that's why we monitor the medications quite carefully, because we don't want to see that. Yeah.
Are there some medications that are prone to antiviral resistance, and then there are some drugs that are not? Is that the case?
Well, some of the hepatitis B antivirus, some of the lamivudines were, the early drugs had a tendency to resistance. They just were, the virus, sometimes, people, they need one amino acid change, and then they're around, the others need more amino acid changes. And so it's more difficult to get around. It's more just having the virus multiplying while the medication, we just want to see it suppressed if we can.
Do we have any other questions from? Oh.
Yeah.
Given that stage of life this group,
yeah.
Dealing with an individual, seeing multiple, how do you actually go through that? Do you do it individually, or do you have something that they watch up to make it really clear about why it's important, what the impact is, so there's a personal and a...
Sure. Well, I suppose if I take this young lad, I don't know, he's 21, it probably took us a few months of appointments, then breaking it down. I mean, I knew it was happening, but one of the problems was he wasn't able to tell the doctor something that was going to upset the doctor. That's a cultural thing. I said, I don't mind being upset. You've gone and done your blood tests, so I'm just showing you what's going on. I thought it was interesting he did the bloods, but then they exposed the truth of what was going on. But I take them through that journey, and I guess he's had Hep B for a long time, he's going to have Hep B, so he doesn't have to know it today. And so you work it through. We did actually work through sort of taking a tablet every day. His girlfriend probably does. So you sort of, I see it as a bit of a journey.
And I guess the question is more whether there's other things we need to be doing to help in providing materials.
Yeah, well, I suppose information in their language. I did come across an app at one of the meetings pre-COVID in one of the Aboriginal languages with hepatitis B, and that was something that struck me. This would be very useful for that in a Karen language that we can give them. They can tap into it. It was a storybook. It was very well done from the Northern Territory. So things like that, so that they've got some... Because I think any of us, if you go to the doctor and you're confronted with what I've just said, sort of wonder what he was talking about and what he's been on. So and that's why I think for general practitioners, it's not possible to get your head around. So either there's some simple tests you do. If these things are lighting up, then you get a referral.
I've had a request from someone who's online.
A friend.
Perhaps
A friend of mine.
the phases of the disease and when we intervene and treat.
Okay, well, I haven't used this board, have I? Okay, so if we... Oh, I haven't got it. Just let me have a think about this. So I'm going to talk about vertical transmission. So this is the baby who's been infected. So obviously the virus is going, and often very high, this is the DNA, in very high levels. So when we see the 18-year-old who's had hepatitis B since birth, and their E antigen, so we haven't even touched on E yet, so their E antigen is going to be very high. E antigen basically tells you that there's lots of turnover of Hep B in the hepatocyte. It's very active, lots of DNA. The ALT, which is, so you've got a liver cell, ALT, AST, live inside the hepatocyte. So these tell us about hepatocyte integrity. So when you, because there's about 4 or 5 liver tests, but the ones we harp on are the ALT, AST. And if you've got hepatitis B there and the liver cells are being broken apart from immune system attacking the Hep B, these are going to spill into the system. And that's what you're going to see elevated. So if your ALT is normal, that's telling us there's no... So it's not the hepatitis B that's damaging the liver cell, it's your immune system. And that immune system may remain very happy, just to take it one more step. So what drives the immune system? That's your white cells. So the white cells come along, the lymphocytes come along, or all your white cells, they come along to the thymus, which is a big gland in a baby. And that's the kindergarten. So that's where they're taught about self. So as I say to people, if your house was robbed today and you said, can you come and tell me what's gone? I wouldn't have a clue. So why would I not have a clue what's gone from your house? Well, I didn't know it was there before. Right? But you do, so you can tell what's gone. So the white cells, if they're going to know about self, so they're going to know what your eye cell looks like, or your heart cell, or your lung, it has to have been introduced to that. So the white cell carries a little filofax of what's self. And if it's not self, then it's foreign. And if it's foreign, I'm going to attack it, and I'm going to release a whole lot of things to get my mates and also come and attack it. So the thought is that when a baby has got Hep B and the cells are going to the thymus, white cell going up to the thymus at the kindergarten, being taught about self, the liver cells already have a spike out of them, which is the Hep B. So the liver cell, these white cells at the kindergarten are being told that's self, that's liver. But the liver's actually already got some abnormality because it's got hepatitis B. So the immune system for a long, long time ignores the Hep B. And so for some people it might ignore it for 20 years, might ignore it for 50 years. We've got people in the clinic, I think even older, into their 60s, 70s. And all the way through, the transaminases remain normal and we don't see anything. So here, the ALT is normal. And then we get a bit of a change because then we decide at some point that the immune system's going to kick in. And so the DNA drops off, the E antibody comes in, and we might just get a few flicks here because that's the immune system coming in, trying to eradicate this Hep B. But it can't, so you get these swirls of treatment. And depending on how much this happens, and then it sort of stabilises again. And the hepatitis B DNA will often be quite low. And then in this phase, that can go on for quite some time. And occasionally you get other changes here, different parts of the immune system kick in, and so you can get the DNA rising again. You can even get the DNA rising. and the ALT remaining relatively normal or up and down a bit. It's in this bit that you can become cirrhotic. So it's in this. So what happens here is that you come in and your immune system attacks the liver cell. Around the liver cell, there's these stellate cells. Now, the stellate cells are the things that lay down the collagen that then cause the cirrhosis, cause the scarring in the liver. So it's activating these stellate cells that really, that's what causes the problem. And so that during here, there's attack of the liver, the stellate cells are stirred up, collagen's laid down, and depending on how much and how many bursts you go through there, you can actually end up here and be cirrhotic. Now, obviously, if you're cirrhotic there, then that's a risk of liver cancer. So what we want to do is we're watching the people here and we're looking for these flicks of the ALT. And then after a certain age, we're also adding in ultrasound. And once we start seeing these flicks, that's enough. And we'll see the DNA up and down, and that's enough to start treatment. And then what we hope to do then is change that graph. So basically the ALT and the DNA is undetectable or very low, and the ALT normalises, particularly if they're not cirrhotic. So the cirrhotic ones, the ones we sort of see because they've had liver disease, they got it as a baby, and then at 50 they weren't very well, they went and had an ultrasound, they've got a liver cancer, they may be in this group, but they're cirrhotic, they've got a liver cancer, and they then have to undertake whatever treatment's appropriate at that point, and many of them won't survive that.